Hello friends, this is Dr. Palak, your mentor for anesthesia. So today our topic of discussion is PDPH, which is post-dural puncture headache. This is probably the first and the most well recognized complication of spinal anesthesia, or not just spinal anesthesia, any lumbar puncture. Now, this particular name, post-dural puncture headache, is somewhat of a misnomer. If you know, we have the spinal cord, right? Then we have pia mater outside, we have arachnoid, which outside of it is the dura mater. Now, your subarachnoid space contains the CSF, right? And so, every time we say a dural puncture, we actually mean a puncture of the dura arachnoid. When both of these are pierced, only then we reach the subarachnoid space and there is a CSF leak. And post-dural puncture headache is the headache that happens after CSF drainage has happened or after the subarachnoid space is exposed. So a bit about its history, how it was recognized, how it was discovered. Now the first surgeon who is attributed for successful spinal anesthesia technique was Dr. August Bayer. You should check out my video on history of neuraxial anesthesia. The stories about it are actually very interesting, and I've explained the story in a bit more detail in that video. Now, Dr. August Bayer, he performed lumbar puncture and rather spinal anesthesia with cocaine on a few patients and also on his assistant, and he also allowed his assistant to do a lumbar puncture on him. And most of his patients, like I think out of 9, 6 patients, and he and his assistant, all of these people had severe headache the next day. And Dr. Bayer was the first one, or with this episode, he also recognized and he postulated that this post-dural puncture headache happens because of CSF leak or loss of CSF from the subarachnoid space. So, and this was back in 1898 when first successful spinal anesthesia was also performed by Dr. Bayer. Now, how do we define what exactly is post-dural puncture headache? Now, International Headache Society, yes, there is a society that takes headaches about headaches. This society gave a certain criteria, described the cardinal features of PDPH. Firstly, the symptoms of headache that develops, that develops within 5 days of dural puncture and worsens within 15 minutes of standing or sitting, basically at least 15 minutes, within 15 minutes of upright position, and hence also improves within 15 minutes of lying down. Basically, a headache that is postural in nature and develops within 5 days of a dural puncture. Along with this, there are some associated symptoms, and of the ones that are lifted, at least one of them should be present, which includes neck stiffness, tinnitus, hypoacusia, photophobia, nausea and vomiting, right? And it resolves spontaneously within a week or after a definitive treatment of PDPH, which nowadays is epidural blood patch. Okay, so all these become the cardinal features, and when all this criteria is fulfilled, we declare that the patient has post-dural puncture headache. A word about the relevant anatomy and physiology for this. The dura mater, if this is the spinal cord, okay, the pia arachnoid, and then we have the dura mater. Now the dura mater that extends from the foramen magnum to the S2 is made up of collagen fibers and elastic fibers, which means that it's a fibrous structure with certain tension to it. Now, initially, it was thought that the arrangement of these fibers was longitudinal. Okay, that is why a lot of discussion about the bevel orientation and how we are whether we are cutting these fibers or whether we are separating these fibers, that was in question. It's still in question, but the reason for it is different. Now we know that these fibers are not horizontally aligned, they are actually aligned in spirals, and they are layered, they are laminated like the ones in the bone, right? The in bone as well, if you look at the ultrastructure of the bone, there also you have your fibers and your osteocytes arranged like this. So they are in concentric circles and they are lying one over the other. But because of its attachment, like its extension from the brain, then the foramen magnum and up to the S2, that it's under some tension, and that tension is longitudinal. So these are like consider a band that is stretched from up to down, right? Even though its threads are stitched in crisscross, but if I stretch the whole band from above and below, so it will be taut longitudinally, right? The same case is with the meninges. Because of this longitudinal tension, whenever, because of a needle, because of a dural puncture, we cut this dura, these fibers will retract opposite, up and down. That is why it is preferable that the dura to be not cut. It should not be cut. If it is cut, it will, the fibers will retract up. If they are only separated, there won't be any retraction. And one of the pathogenesis for PDPH is not just CSF leak, it's actually persistent leak. So this tear should not stay for a longer time. Okay, a little bit about CSF. Now, our CSF is the fluid that is produced by the choroid plexus of the brain. It is produced at a rate of 20 ml per hour or 0.35 ml per minute. Its daily production is 500 ml per day, and total amount is 150 to 200 ml. Of this, 25 to 75 ml is present in the spinal canal, and you can remember this figure here, right? Like 150 ml in total, and its half is 75 ml is present in the vertebral canal. Now, if if more than 10% of CSF volume is lost, then we will have this PDPH or the postural headache. With this normal amount, the normal lumbar opening pressure, that is the pressure against which I will pierce the dura and the CSF will gush out, is 5 to 15 centimeters of water in horizontal or supine or lying down position, and 40 to 50 centimeters of water in standing or upright, the vertical position. Now, as I told you, not just a CSF leak, a persistent CSF leak is the major pathophysiology for PDPH, and it is estimated that more than 10 ml per hour of leak, if happens, is a high risk for post-dural puncture headache. Now, what is the etiopathogenesis? There is a tear or puncture of meninges. Why I'm saying meninges, I told you in the beginning now that it's not just the dura being cut or pierced, it's the dura arachnoid. That is why I found a couple of texts where PDPH was better referred to as meningeal puncture headache rather than post-dural puncture headache. Okay, so if there is a tear in the meninges, and if that tear leads to a persistent CSF leak, there is CSF loss leading to reduced intracranial tension, there is intracranial hypotension, okay? And because of this, two things happen. First, our brain tends to sag down. Our brain is actually sitting in the pool of water of CSF. One of the functions of CSF is to create buoyancy and reduce the effective weight of the brain. And so the brain doesn't sag down, and all the, if you remember the inferior cranium, there are openings, right, from where all your cranial nerves and spinal cord and they are emerging. We used to read all those openings, right? So if the brain sags down, there is a traction that comes on the pain sensitive structures, which include your blood vessels, um, the cranial naves, the tentorium cerebelli, the meningeal folds, basically, right? That causes the headache. This, there is fall in ICP, right? Because of fall in ICP, there is reflex vasodilation to compensate for the volume. Why this happens? There is a hypothesis for cerebral physiology. I'll deal with that in the video when I deal with cerebral physiology. Now, Monroe Kelly hypothesis. This hypothesis states that the total cranial volume is constant, and that volume is made up of blood, brain, and fluid, which is CSF. So if one of them reduces, the other will increase to compensate to keep this volume constant, and hence there is a adenosine mediated reflex vasodilation, and also there is some perivascular edema, which also causes pain. Now, here we read that the cranial nerves come under tension. Now, whichever cranial nerve we talk about, whichever cranial nerve is under pressure, there will be some palsy. The visual disturbances that we see, they come because of transient palsy of the cranial nerves 3, 4, 6 that supply the extraocular muscles. Okay, then we have some vestibulocochlear and auditory symptoms, and that happens because in your vestibulocochlear system there is perilymph, and perilymph comes from CSF. If the CSF pressure is low, if there is loss of CSF, the perilymph also reduces, and hence we have vestibulocochlear symptoms as well. Because of vagus, you get occipital headache, you get nausea and vomiting. Very important, nausea and vomiting. This is the most common symptom, apart from the headache, of course. Okay, so this becomes the pathophysiology of all these symptoms. Now, what are those symptoms? First, we'll talk about the onset. So there obviously is a headache. Okay, the main is the headache, the onset of which is mostly within 48 hours of a lumbar puncture. If not within 48 hours, at least within 3 days. Most, like 90% of the cases present within 3 days, which is 72 hours. And rarely it so happens that it can take more than 5 days. That is why in the clinical definition, the criteria of 5 days is made, that within 5 days of LP, if we have a headache of a certain character, then it's most likely PDPH. The character of this headache is throbbing. Dr. Bayer himself described it as a constricting band around the head. Then the location of this headache can be occipital, which is the most common, right? It could be occipitofrontal. Alone isolated frontal is rare, and there is radiation to neck and shoulders, and it is always bilateral. Okay, One of the things in the most important of the character is the postural nature, that it worsens within 15 minutes of upright and it improves within 15 minutes of lying down. And this postural nature of this headache that happens after a dural puncture is the hallmark character of this headache. Then it resolves spontaneously within a week, or 48 hours, within 48 hours of an epidural blood patch. Okay, these were the main symptoms. Then there are many associated symptoms which happen mostly because of the cranial nerve palsies. I told you there are visual disturbances. The visual symptoms are diplopia, photophobia, blurred vision. Okay, and they happen because of 346. Most common of the extraocular muscle palsy that happens is of the lateral rectus muscle, probably because it is supplied by the cranial nerve 6, and cranial nerve 6 has the longest intracranial root, so probably it gets affected the most. You have some auditory symptoms in which there could be tinnitus, there could be hearing loss, hypoacusis, right? There could be vestibular symptoms of vertigo, okay? There could be seizures. Then one of the dreaded symptoms or sequelae of PDPH is SDH. That happens because as your brain sags down and there is stretch on the dura, the blood vessels that are passing through the dura, they can get torn. The cranial nerve symptoms are although usually unilateral. The headache is bilateral, but these symptoms are usually seen unilateral. Now, as such, there is no classification, but there is a categorization, the severity categorization based on the VAS score, the extent of interference with the daily activities, and presence of associated symptoms. So, a headache which has a VAS score of 1 to 3 with minimal or rather no interference with the daily activities, the patient is not confined to bed and there are no associated symptoms, that is categorized as mild. If the VAS score is 4 to 7 with some interference in the daily activities, the patient is confined to bed for some days, then it and associated symptoms are present, then that is categorized as moderate. And if the VAS score is 8 to 10, the patient is confined to bed, not unable to stand and do the daily activities, and associated symptoms are also present, then it is considered as severe. These were the symptoms. Now, what are the signs? Signs are not many. Some people observe that if you give a bilateral jugular pressure, that tends to increase the headache. Then there was a test called sitting epigastric pressure test, in which you made the patient upright, you waited for the symptoms, you waited for the headache to come, right? And once that happened, you would compress the stomach and you would observe that after 15 to 30 seconds the headache reduced, right? Probably because you're pressurizing the abdomen would compress the subarachnoid space as well, and for a little while that sagging down of the brain, that intracranial hypotension, that gets corrected, and this headache it increases again once you remove the compression. Now, having known the signs and the symptoms, how do we diagnose? Diagnosis of PDPH is mostly clinical. Okay, so you have the characteristic symptoms, you have some signs, you have a history of dural puncture with associated signs and symptoms. Okay, and along with that, there are certain investigations that we can check if we can confirm the spinal source of CSF leak. Listen, CSF leak could even happen in a traumatic brain injury. It could even happen in an inner ear injury. Okay, so inner ear surgery. Sorry. So if we cannot call them as post-dural puncture headache. Like if we have to call it post-dural puncture headache, we should know that there is this loss of CSF and there was a dural puncture or the spinal source of that leak. So in order to confirm that spinal source, we can do a CT myelography. We can do a retrograde radionucleotide myelography. We can get a thin section MRI, or we can even do a cysternography. Then, what are the features when you get on an MRI brain? If a patient is suffering with PDPH and you get an MRI, you will see signs such as meningeal enhancement. Then there could be subdural fluid collection, not necessarily a hematoma, but there could be some fluid collection. There would be engorgement of the venous sinuses of the brain, and your spinal epidural venous plexus, right? That would have become prominent. So these are the signs that you should look for on an MRI. But mostly we make this diagnosis based on clinical signs and symptoms, and also when we rule out the differential diagnosis. Differential diagnosis is a very important thing. One should rule out these before declaring it as PDPH. Now, a patient could have headache after surgery, which could be infective. Rather, after a dural puncture, there could be infection like meningitis or encephalitis that could be causing pain. There could be vascular reasons for headache, such as migraine, then subdural hemorrhage, subarachnoid hemorrhage. Subdural hemorrhage could happen as a sequelae of a postdural puncture headache because of the intracranial hypotension and tearing of the blood vessels. Subarachnoid hemorrhage could happen because of the aneurysmal bleed. Like we don't know always if a patient is carrying a subclinical aneurysm, right? So because of the intracranial hypotension or because of the surgery and and the mean arterial pressure being fluctuating, probably the aneurysmal rupture happens unfortunately, and that could cause headache and other signs. Now there could even be cerebral vein thrombosis, right? Remember cavernous sinus thrombosis, that can also cause headache. This headache could even be neoplastic in origin because of a space occupying lesion, right? Then other benign differential diagnosis could be, it could just be a non-specific headache, right? It could be because the patient is dehydrated either after a surgery, most often seen after labor and childbirth. It could be a tension headache, right? And as we have seen PDPH cases, most of them we see in obstetric patients. Always remember to rule out pre-eclampsia and eclampsia. There could be seizures with PDPH as well. So if you have a patient who has seizures post-delivery, I would first consider eclampsia and pre-eclampsia. There is an entity called as postpartum eclampsia as well, where whole pregnancy goes uneventful. It's only after uh, delivery that a patient throws a fit. So rule out preeclampsia and eclampsia. This headache could even be because of sinusitis. Certain drugs could cause, and the most commonly drug in this setting would be ondansetron. So this concludes part 1 for PDPH. I'll see you in the next part.